So welcome everyone to the coffee convo for tonight. We're going to be talking about picky eating in individuals with autism. I'm Sarah Kadzielski. I'm a pediatric gastroenterologist at the Lurie Center. And then,
Hi, I'm Briana Brukilacchio. I am a psychologist at the Lurie Center.
so hopefully we'll give you some helpful information or at least a starting point. I'm assuming for those of you who are on the call that there's someone in your life that's a picky eater. So hopefully, again, we might give you a starting point, or if you're already a little further down in the process, we might give you a jumping off point again to sort of gain momentum and make some progress. So in terms of the agenda, and sorry, we're gonna go through our talk first, and then we definitely have plenty of time for questions at the end. So if you don't mind, we'll try to talk through the slides first, and then we'll do questions after that. So we're going to talk about, in general, picky eating, and then more specifically beyond picky eating, some general recommendations, and then we'll touch on some behavioral intervention strategies, which is probably the reason most of you guys are here. All right, next slide. So when we think about picky eating in autism, in general, it's a fairly common phase in early childhood. So most studies looking at feeding issues in kids show that feeding concerns peak around age 3. And it's often related to the time when they're developing increased autonomy and independence. They learn how to say no. And so this is one of the ways where they are able to assert their independence. Rejection of vegetables is one of the very most common ones. You might see some preferences that come and go. Maybe one day they eat a food and then the next time you offer it, they don't eat it. They might request foods to be prepared in specific ways. Don't cut my sandwich in squares. I want it in triangles today, but tomorrow it might be squares. So, and then they might request foods other than what was prepared. So you make a whole dinner and then they ask you to make, and then they ask for cereal or something like that. And picky eaters might appear pickier if they're in a new setting. Generally, in the picky eater category, they're still going to eat at least 30 different foods. And there are at least some foods in every major food group. In this category of picky eating, despite sort of the changes from day to day or minute to minute, it usually doesn't impact the nutrition. Growth and weight gain are on track, and the picky eating concerns resolve without any specific intervention from the healthcare providers. And so for this category, the typical pediatrician, what I was taught in training is that, don't worry too much about one specific meal or even one day, but sort of look at what they eat across an average of like a week. And that if they're growing okay, that should be sort of reassuring, and that within those ranges, the picky eating is a fairly common phase. When we get beyond picky eating, so this is probably why most of you are here. So feeding difficulties are 5 times more common in individuals with autism than without. These picky eating behaviors persist beyond the early childhood phase, so beyond age 3. These people may only eat several foods, and less than 20 is sort of a cutoff. And then there are entire food groups that the individual doesn't accept foods from. So maybe no fruits or vegetables or no protein, but the whole food category is missing from their diet. We may see some considerable meltdowns and behavioral struggles around meal times, and they might only eat food in certain places. So maybe they will only eat at home, or they won't eat anything at school, or maybe vice versa. They'll only eat certain foods in certain places. Next slide. When we talk about beyond picky eating, there are some health concerns. Especially, it makes sense if they're missing a whole food category, then we need to get concerned about nutritional deficiencies. What the growth curve tells us is if they're getting enough calories, protein, fat, and carbohydrates in their diet, and they're getting enough calories to grow. But the super picky eaters can have a diet that's doesn't have enough fiber. And that can lead to medical complications. And then specific vitamin deficiencies that are common depending on which foods they eat or don't eat would be an iron deficiency, so especially in people who are not eating very much meat. vitamin D and calcium for those who aren't getting much dairy. And then zinc, vitamin E, and vitamin B12 have all sort of been picked up in studies of looking at very selective eaters. If they are not getting enough calories in, and I think it depends sort of which are the preferred foods. So if they're preferring high calorie foods, maybe the calories are okay and the weight is okay. But if they tend towards lower calorie foods, then they might be underweight. And so they might require some supplementation. So the most common formulas that can be would be like a Pediasure in younger kids or Ensure in someone who's older. We wonder sometimes if there are sort of chicken and the egg, like are there medical issues that are affecting their eating and contributing to selective eating, or is the selective eating causing some medical concerns down the line? So as a gastroenterologist, one thing that's always on my list to think about in people who are having eating issues is if they're having some pain in the esophagus, so in the food pipe, which could be like acid reflux or vomiting. If they have difficulty swallowing the food down, that's going to lead to a restrictive diet in terms of which foods they're able to get down. People with cavities or tooth decay, that might affect what they're able to eat, and so they might prefer softer foods or purees or only liquids. Heartburn and reflux sort of is in the same category. I mentioned the people who are not getting enough fiber. Constipation is a very common issue, especially in people who are not eating many fruits or vegetables. If the calories are not enough, they might lose weight, or if they don't lose weight, they might not keep up with the expected weight gain on the growth chart. So when you go in for their regular annual visits, you might see that instead of staying on a line, they're sort of falling from one line to the next. And on the other side of things, again, depending on sort of what the preferred foods are, we can also see kids and young adults who struggle with overweight or obesity if their preferred foods are higher in calories. And then fatigue, very low energy, can be associated with iron deficiency and anemia. When you don't have enough iron, then you don't make enough red blood cells to carry oxygen throughout your body, and that can result in being fatigued or sort of low energy levels. One consideration for the picky eaters is something called ARFID, which is avoidant restrictive food intake disorder. This is an eating or feeding disorder that's not related to body images concerns the way you think of in some other eating disorders, such as anemia or bulimia, or anorexia or bulimia. And it's not driven by an urge to lose weight. So it's not around the weight, but it's about the actual process of eating. There are much higher rates of ARFID in individuals with autism. And for these symptoms, it persists beyond the early childhood phase. It can lead to nutritional deficiencies. It can impact growth and weight gain, so both height and weight. It often requires supplementation either from a formula like a Pediasure or vitamins. And the ARFID can cause considerable psychosocial impairment. And by that, we mean severe tantrums, aggressive behaviors, running away or hiding around meal times, throwing food if it's non-preferred. And it can really limit participation in school activities. So these may be individuals who aren't able to eat all day long at school. It can impact families' ability to travel or go out to eat in a restaurant. In kids who, as they get older, they might not be able to go spend time with friends because they might not have access to foods that they feel comfortable eating. And within the ARFID diagnosis, there are three types. There's the first type is sensory avoidant, and these are people who will intensely avoid foods with certain colors or certain textures or certain smells. Aversive, the second type is aversive, and in this type, they're refusing to eat because of the fear of choking, a fear of nausea or pain or vomiting. And there can be many interrelated things that once, maybe they had a stomach bug and then after that they became scared to eat, like they had to vomit and then after that they've become scared to eat because they really intensely dislike vomiting and so they avoid eating in general. And the third type is restrictive. So with this, there's just a low motivation to eat. This might be due to limited appetite or limited interest, or just high distractibility at mealtimes. If you have a hard time sitting at the table for, 15, 20 minutes to eat your full meal, then you're not going to be able to get enough of your necessary nutrition in on board.
I'll say, I'll just jump in here to add that in kiddos with autism or adults and adolescents with autism, you might have guessed that sort of the subtype here that we most commonly see for ARFID is the sensory avoidant one. So there's a lot of avoiding of foods related to some of their sensory properties. It's less common that we see that subtype that's just purely about kind of low interest, limited appetite. And with the aversive subtype, that can be kind of tied to anxiety. So in some kiddos with autism who are also really high anxiety, you might notice some of that kind of fear-driven component, especially intense fear of new foods. So kind of particularly when you're introducing something new, you're noticing a lot of those reactions. But the aversive subtype's more common in kiddos who have another kind of complex medical condition or have had some kind of experience in the past, like you described, vomiting, and now they're afraid to eat something again, or an extreme allergic reaction, and now they're afraid to eat foods again. Yeah.
So in terms of general approach, what we would suggest is first discuss your concerns with a PCP. So the pediatrician is going to be your first point of contact. A clinical evaluation, think about referrals to other providers as well. Address nutritional inadequacies. So we talked about sort of vitamins or calories, and then some behavioral interventions as well. Regardless of whether there's an underlying cause, I think the behavior piece of it can be so strong that even if you treat the underlying cause, it's really important to address the behaviors behind it, because those are often last longer than whatever the individual, like if there was a specific cause of the initial feeding concern, the behaviors are longer term issue. So meeting with the PCP or the pediatrician, as you know, they almost always get measured at least at their regular annual checks. So looking at the growth parameters, so their weight and their height, and is their weight appropriate for their height? Thinking about getting some blood work done for some of those vitamin deficiencies that I mentioned, especially for very, very extremely picky eaters. And then thinking about additional tests or referrals, which I think we have on the next slide a little bit more details. And then the clinical evaluation. So this may be sort of some questions that the pediatrician might ask, or if you end up seeing a gastroenterologist, they might ask about this, or if you see a feeding evaluation, which includes speech therapy or occupational therapy. These are some of the things that people might ask you about in different ways. So I find it helpful to think about feeding concerns in sort of a couple different categories. One is if you can't eat. So these might be kids that or adult. I'm sorry, I say kids because I'm a pediatric gastroenterologist, but this applies to all different age groups. So the can't eat category might be difficulty with the muscles. So maybe low tone in the mouth, the lips, the jaw, the tongue. And so these who might have trouble chewing things with, that take more chewing, they might prefer softer foods like purees or liquids. Or more like the dissolvable foods that they don't have to chew as much. The second category is it hurts to eat. And so this sort of contributes to that aversive ARFID subtype. So if you have pain is a really strong motivator to avoid something. So if you have pain and you know that doing a specific thing every day, like eating 3 times a day, causes you the pain, over time, you're going to be less interested in doing that thing that causes pain. And so it's not always from the GI tract. It can be, there's a lot of spots along the way that can affect eating. So it can come from tooth pain or jaw pain, ear infections, or ear pain can actually, that it's all related sort of in the back of the throat there. And so that can contribute significantly. It can be from some abdominal pain. So I mentioned acid reflux already. There's another condition called EOE, which stands for eosinophilic esophagitis. And that is a different condition that causes more like an allergic inflammation of the throat. And over time, it can be hard to swallow. And it can lead to, again, sort of a reduction or selective eating, sort of sticking to foods that are easier to swallow. Constipation, as I mentioned, is sort of in that chicken and the egg of that kids who are picky eaters are often constipated because they don't have enough fruits and vegetables and fiber in their diet. But then once you're constipated, every time you eat, you get peristalsis, which means your intestines are sort of squeezing and trying to move things through. And so often kids who start getting pain right after they eat, it can be associated with constipation, because once there's food in your stomach, you sort of get this the reflex that it turns on your digestive tract. And if you're constipated, that can be very uncomfortable. Celiac disease is an autoimmune condition related to gluten, which is the protein in meat. And that can cause a really wide variety of symptoms, including GI pain, vomiting, nausea, diarrhea, weight loss, or poor weight gain. It can contribute to some of the vitamin deficiencies, and rashes. There can be a lot of other symptoms as well. And that is easy to rule out or rule in with a blood test, and then if that's abnormal, with an endoscopy procedure. Irritable bowel syndrome is another common cause of abdominal pain. Lactose intolerance or some other food sensitivities can also contribute. So if from a GI perspective, we sort of dial in on and trying to figure out if any of these things might be at play. And then the third reason to think about feeding difficulties would be if they won't eat. And this can be sort of that category that we were talking about on the previous slides, the fear associated with severe food allergies, or a choking or vomiting event. Kids who maybe have a low appetite sort of in general, or maybe they're on medications that suppress their appetite and so they just don't feel hungry. Sensory sensitivities. So again, the color, the texture, the temperature, the shape, the presentation can be part of this. And then insistence on sameness. So kids who want the things to be the same. So maybe this is processed foods, maybe this is specific brands. I know some kids who will only eat one specific flavor of yogurt, but only if there's a specific character on the package. And if they change the package, then even though the yogurt's the same on the inside, they won't touch it again. But sort of this, and the same thing with the processed foods is that if you want things to be the same and predictable and taste the same and look the same, it's much more easy to get that in something that comes out of a package because of the way that things are manufactured, or if they're made in a restaurant. Like the French fries from McDonald's are going to be pretty similar almost every time. There might be some that are a little more cooked or crunchy than others, but there's much less variety or variation versus something that's homemade where it might be different every time. And so that sort of all fits into the meat category. So in terms of additional referrals, depending on if you're seeing some of those medical complications, or if you feel like you've exhausted sort of the first line, which of approach. So additional referrals might include a dietitian or a nutritionist. And sometimes when I mention this at first to families, I will hear, well, we already met a nutritionist and they just told us what foods our child should eat. Like, we already know that. We already know they should eat fruits and vegetables, but we can't make that happen. But where we find the nutritionist helpful is that they might be able to target specific vitamins or food categories where we can sort of, if calcium and vitamin D is an issue, figuring out creative ways to get the more of the necessary vitamins or calories into them. Pediatric gastroenterologists, again, to sort of think through some of more of the GI diagnoses and the testing, and possibly doing an endoscopy if it makes sense for what the symptoms are. And then not as commonly, but sometimes people will end up seeing ENT, which is an ear, nose, and throat doctor. I have seen some kids who have maybe very large tonsils. I've seen some kids who have very large tonsils and it doesn't cause feeding issues. But some kids with very large tonsils who maybe are also snoring and have some sleep apnea, sometimes when they end up having their tonsils taken out, then the feeding improves as well. So sort of thinking through additional supports. And then step 4 is addressing the nutritional inadequacies. So this could include, again, if calories and weight are low, we might start by just going through some ideas about high calorie foods. So dairy products for someone who tolerates dairy, okay. Dairy is usually an easy way to bump up the calories. If you do it too much, it can make constipation worse. So of course you have to kind of keep everything in a balance. If you're not able to make progress with those high calorie foods, sometimes we end up going to supplements, like I mentioned in previously, like a Pediasure or an Ensure. Sometimes, as some of you know, it can be it's not that easy to just replace one thing with the other. So it might be a really slow process. If they're milk drinkers, that you just add like a half an ounce of the Pediasure, and then over several weeks, you eventually increase the Pediasure and decrease the amount of milk. And then thinking about the vitamin issue, so starting a multivitamin or specific vitamins if they're low. I think for if we're in the picky eaters who are gaining weight, okay, they might not need it, but in the beyond picky eaters, I would say definitely it's a great idea to work on a multivitamin. That might also be a project to get them to find one that your child will accept. The easy ones to find are like the chewable, crunchy ones or gummies. But that doesn't work for everybody. There are a lot of other options now. There's a bunch of options. There are some powdered options. There's dissolvable ones that you can put in your mouth. Either you let it dissolve on your tongue, or those you could sort of pre-mix with water and make it into a liquid. But I think every year we see a few people with really severe vitamin deficiencies, and a multivitamin, even though it might not target like very specific ones, a multivitamin is a really easy way to protect against some of the more severe problems that you can see. And then if the calorie supplements or the high calorie efforts don't stick, sometimes we'll consider using a medication that increases appetite. I will say in my experience that doesn't necessarily improve the variety of foods that they will eat. It just makes them more hungry. And so they might just eat more of their same foods. But at least if we can fix the weight issue, that at least takes one thing out of the equation. And I also find that for the ones who do need the medication to increase their appetite, that sometimes works really nicely when it's paired with other behavioral strategies. So it might not work great on its own to increase the variety. But if you end up in feeding therapy, which I know we'll talk about later on, but if you show up to a feeding therapy session and you're hungry, you're going to be a lot more willing or more likely to try a new food than you would if you're not hungry at all. So sometimes that can work well together. And with that, for step 5 is all the behavioral interventions. So I'm going to turn it over to Bri.
Sure. So behavioral interventions, this could span many different kind of contexts. So I always recommend parents think about who's already on your team, who's already on your child's team, that you can begin kind of pulling into these conversations around picky eating now. And who do you want to add onto that team? So if you already have a behavioral therapist, an ABA therapist, especially somebody who's working in home, that would be a really great resource. A lot of the strategies that we're talking about are really behavioral in nature. And so an ABA therapist is going to be in a really good position to help you implement some of these different behavioral strategies. An occupational therapist might also be able to provide some suggestions and kind of work with you on approaches to support your child's eating. A feeding therapist and a feeding therapy evaluation are really the piece I strongly recommend when feeding and eating are kind of a persistent or really tricky concern. So first, tapping those resources that you already have, then really seeking out that feeding therapy evaluation. If you're looking for an outpatient feeding therapy evaluation, check in with your child's pediatrician or their primary care physician. They should be able to help you find a referral that's appropriate based on your insurance and the area where you live. Oftentimes, those are either multidisciplinary in some way, meaning there are a few different types of clinicians or providers who are participating in that evaluation process. Or you might see that they're primarily led by a speech therapist or an occupational therapist. But they're going to do a lot of what we talked about earlier in that sort of the slide that was referencing, can't eat, hurts to eat, won't eat. They're really going to be exploring a lot of those through the questions that they ask you and also some of the activities that they might have your child do directly. Another resource that may be appropriate, especially if you have a child, an adult child or an adolescent child, could be a psychologist. There are different types of cognitive behavioral therapy approaches that, depending on the sort of language and overall profile of the individual, might be a good fit potentially. So thinking about a psychology referral, if this is really persistent later on in the life course. And then there are also lots of resources that you can reference that I think are quite good and can be really helpful. One in particular is a toolkit you can see on the slide here by the Autism Treatment Network. And I didn't mention school supports yet. I will say this one sometimes is useful and sometimes is actually a place where parents find a lot of resistance or difficulty kind of getting buy-in. Most schools will not really work on eating and feeding as an intervention that they're targeting as a part of a child's IEP necessarily. But you may be able to ask for certain accommodations for your child that might require kind of a doctor's note to help make the case for, but things like supervised meal times. So during lunch, is there a paraprofessional or a teacher who can sit a little closer to your child to kind of supervise and keep an eye on how things are going, maybe to monitor or informally collect some data around what percentage of their meal are they eating, or have they touched their meal? Have they opened anything that you sent them home with that day? So that would be one suggestion. Sometimes schools will, with letter of accommodation, allow families to send food in for the child rather than having the child eat food that's available at the school. So again, this really depends, and sometimes that's helpful as part of the child's overall kind of approach to intervention. And sometimes actually having that exposure to novel foods in a school setting is maybe a goal. So we don't always want the same accommodations across the board for each and every child. Now I'm going to talk through different specific suggestions, approaches to your communication at home with your child around meal times. But as we're going through these, I want you to think about who's kind of, again, on your team to help you with these things. It's a lot of work. Excuse me, I do have the cold that's going around right now. So some general guidelines, and you may have already tried many of these things, but just bear with me because I think it's helpful to lay a good foundation here. It's helpful to expose kids early to a variety of foods. Even if, as you're listening to this, you're thinking, well, my kiddo right now is actually a typical picky eater. We haven't yet moved into the beyond picky eating. That's great. Maybe continue exposing your child, your toddler, to a variety of different foods to help increase the likelihood that maybe they'll warm up to some of those other ones down the line as well. Increasing structure and consistency around meal times. This is really, really helpful. And as you all probably know, kiddos with autism in particular really benefit from structure in general. So applying that to the mealtime framework can be really helpful in allowing kids to understand what the expectations are. And this also helps to kind of minimize grazing throughout the day, which you'll see lower on the list. If you have consistent meal times, 3 meals throughout the day, and 3 snacks sprinkled in there at predictable times, and in between those meals and snacks, you can kind of refer to, the kitchen is closed right now. That's really healthy. If your child is getting 3 mealtime opportunities and 3 snack opportunities throughout the day, they're not going to starve in between those. And so it is absolutely okay to close the kitchen. And actually, teaching your kiddo to understand those hunger cues is really helpful and really important. So when it is time for that next snack or that next meal, you really help them recognize, oh, my belly is so hungry. Oh, I'm ready to eat something. When kids are grazing throughout the day and snacking on lots of things, they might also have good reason to not have much of an appetite at meal times. So again, this just kind of sets things up to be a little bit more effective when mealtime comes around. Minimizing distractions at meals. I suggest kind of not having the TV on in the background, not having the iPads at the table, trying to keep things really contained and focus on the meal itself. Um, the power struggle piece. I know from parents this is absolutely pretty pervasive. A lot of people have difficulties with where to draw the line here because we want to make sure our kids are eating and it's so important that they're getting enough food. We really, though, don't want to force kiddos to eat. So force feeding, fighting about food, pleading, bribing. If you please eat this one piece of food, then I'll get you an ice cream cone, or then you can watch your favorite show. It is okay to use rewards, and I'll talk about that a little bit later, but the way in which you do it is important. We want to move away from anything that feels like we're trying to kind of manipulate kiddos into eating. It is helpful if you start trying to just to increase that exposure to food again. Bring your child with you to go food shopping, or let them kind of watch or help as you're preparing foods in the kitchen. Look at recipes together, or look at cooking videos together as just an exercise, just something recreationally that you're doing together. Thinking back to the insistence on sameness piece that was mentioned earlier, and the fact that some kiddos are really particular about the brands of certain foods, it's helpful if you can avoid presenting food in its packaging. So if you have some tortilla chips that are a part of your dinner that night, don't put the bag on the table and pour them into the bowl right in front of the child. Do that in the kitchen maybe, and then bring just the bowl of the tortilla chips out. So you want to minimize the likelihood that a child is making an association, kind of that visual association between the packaging branding and the food that they're eating. Because in kiddos who really like that consistency and that insistence on sameness, as soon as they start making those strong associations, you may start to see that they're then refusing when you introduce a new brand of the same food. And then just in your own kind of mealtime behavior or the way that you approach eating, setting a good example for just pleasant, healthy eating with a variety of different foods. And even as kind of different behaviors come up at mealtime, make an effort to remain as calm as possible. I know it's incredibly stressful, but try not to react strongly. Again, we know just basically behaviorally, a lot of kids are actually pulling for or enjoy that kind of interactive element or attention element that they get from parents or siblings or other people in the household. So kind of trying to keep things level and calm, ignoring some of the things that you don't necessarily want to see, but really laying on the praise for the behaviors that are kind of adaptive for eating. As you're kind of going about trying to improve some of your kids' eating strategies at home, one of the places to start is just by understanding the lay of the land as it is right now. So collecting some information sort of passively. We call this kind of creating a food diary, where you can see an example here on the right side of the slide, where you're looking at different days of the week and you're thinking about each of those mealtime and snack blocks. And you want to take some general data. You don't have to have a 5-paragraph essay about each meal, but just jot down some notes that you think might be helpful. Things to kind of keep a lookout for are, when was the meal provided? That way you're going to start to notice, oh, what's kind of the consistency level here? What are we always kind of generally doing breakfast at the same time, or this late snack, is it always falling around the same time, or is it kind of variable throughout the week? When is the meal cleared away? So are the meal times kind of prolonged and kids can come and go from the table and the plate sits there for a long time, or is there a constrained sort of meal time and that's it? So just again, this is just about taking data just to notice what's already happening, non-judgmentally, just gathering information. Pay attention to where is the child eating. So snack time, eating in front of the TV, watching Bluey, okay, great. We know where the kiddo is. What's happening during the mealtime? Again, watching TV, watching Bluey. Collect information about the food itself and the eating behaviors. So, what food is presented? What was the snack? Or what foods were on the plate? How much of those foods? Was it an entire plate of, dinosaur chicken nuggets and then a little side of some peas that you're trying to get them to eat? Again, just good information to know kind of what is the breakdown there on the plate. And what food is left? Okay, great. All of the dinosaur nuggets are gone, but all of the peas are still there. Just noticing that. And how did the child interact with the food? Did they touch one of the peas? Did they throw a pea across the room? Just kind of figuring out what's going on. As you maybe start working with a therapist, this is going to be likely where they also start, is just collecting information, just trying to understand what's already happening for your kiddo. The next step is to kind of look back on those food diaries that you've created for yourself and kind of think back on some of the recent meals that you've been making for your kiddo and start to think about foods in different food group categories. And you can kind of begin tracking, are they consistently eating this food? Are they willing to maybe tolerate or learn about this food? Or are they unwilling and unable? So when I think about the green category, this is going to be something that, yeah, on a regular basis, my kiddo or my teen or my adult will drink apple juice and they will eat strawberries. So mark, those are in the green category. In the unwilling, unable category, every time we try to present them with cranberry juice, they push the cup over. Or every time I give them grapefruit juice, they gag, right? So, okay, those are pretty strong no's. When you think about the fruits, same pattern. In that yellow category, I find that the green and the red are the easiest for people's minds to jump to. You know what's in the green and you pretty much know what's in the red. Spending a little time trying to figure out what might be in that yellow category is worth the time investment, because that's where a lot of the opportunity is going to lie. Grape juice. Oh, well, actually, they were kind of okay with it, especially the white grape juice, because it also kind of looked like apple juice. And they were sort of similar enough that, yeah, they didn't love it and they asked for apple juice the next time, but they did take a few sips. Okay, great. Mango juice. I don't know. We've never tried it. Okay, if we've never tried it, let's maybe put it in the yellow category. Orange juice. Again, maybe they're willing to take a few sips. They haven't outright rejected it, but it's not their preference. And then you can kind of see the same here for blackberries and raspberries in the berry category. I also like this example because you might just sit back and notice there are some themes here. The cranberry juice, the grapefruit juice, cranberries, those are all pretty tart, right? So if we're thinking about the sensory aspects of food, a theme that's coming up here is for this eater, tart foods, really sour foods, that may not be in their kind of taste profile. So that's a good kind of overall theme for us to notice and kind of guide our selection moving forward. Then when we think about the berries, well, blueberries, they're kind of mushy. They're kind of different each time. Some of them are really squishy. Some of them are kind of hard. Some are tart. Some are almost a little tasteless. Maybe there's too much variation there, but they'll eat raspberries maybe, and raspberries are kind of similar in form to blackberries. So maybe there's something similar enough there that we could try both. So this all is going to help you from kind of a strategy perspective to think about which foods are you potentially going to target or aim at as you're introducing new types of foods to your kiddos. So again, start with that yellow category from the previous slide. Anything that you think they might be willing to tolerate or try. You also then, and this is where working with that dietitian or nutritionist can be really helpful, if, you've done some blood work with the PCP or the gastroenterologist and discovered that, oh, there is a vitamin, B12 deficiency. Okay, what are some foods that maybe are in that yellow category and might also be high in B12 that we could kind of incorporate in as, top of the list target foods to add. Also think about just quality of life and psychosocial functioning. Is there a particular type of food that if your child is going to accept that more readily, it's going to make different social situations easier for them? One that comes up a lot for kind of preteens and teens who might be starting to try to explore some sleepovers or more of the social gatherings, parties, birthdays, is pizza. A lot of these events have pizza. And if you can work on incorporating pizza as a food that your child will readily accept, that might have a lot of kind of positive social impact. Also, just think about your family. What foods does your family eat? Are there certain foods, ingredients that run through a lot of the different recipes that your family often uses? Are there certain dishes that are really important to your family or your culture that might be really important to kind of focus on helping your kiddo warm up to? And if somebody does have a really, really limited diet, if you're working with a 12, 13, if your kiddo is a 12, 13-year-old, and they've only been eating about, 20 to 25 foods for their whole life, and they're just starting to add new foods, maybe tread lightly as you're incorporating foods that could have a high allergy potential, and just check in with the pediatrician to figure out, can we introduce this? Should we introduce this? How should we do it? Just things like peanuts or tree nuts, common allergies might be something to think about. Because, if they've never been exposed to it ever before, it's something you want to be sort of prepared for. Once you've started to select some of the goal foods that you're aiming for, then you look back at the kind of the green category, things that your child is already consistently eating or accepting on a regular basis, and you want to start there. So one strategy that you can use to go from the green category food to a yellow category food is what we call food chaining. So this is really about making very small, purposeful changes with each new food that you're introducing. So instead of, if your child likes goldfish, okay, got it. They're this like golden yellow orange color. They have a cheesy flavor. They're crunchy. They're small. These are some of the different properties. What's one thing that we can change a little bit, but mostly those variables are staying the same? Cheez-Its might be a good option. Same color, same texture for the most part, similar taste, but the shape is different. So we've introduced something a little bit new. Excuse me. Next, you might think about, oh, the different type of Cheez-Its. Maybe we're going to try the white cheddar Cheez-Its. They're a new color, but the same texture, same taste, same shape. So kind of on and on and on. And in this way, you move from something that's a safe, familiar food to branching out bit by bit in a way that's really low stress, potentially low novelty, to help your child branch out to other foods. I'll say this might take a lot of time, even just that first one that you're trying, just going from goldfish to Cheez-Its, especially if your child is really motivated by that insistence on sameness, or any change is really overwhelming and distressing for them. This is essentially an anxiety exposure in that case, right? So it might take time. And I'm going to show you some strategies where if we're in the phase of really helping kids to warm up to and get used to tolerating the presence of a new food, how you can do that. You don't have to jump straight to the goal of getting them to actually eat the Cheez-It. There's some in-between steps. But first, I want to talk a little bit about family communication around eating. There are some things that we want to sort of avoid in the way that we're talking about food and talking with our kids around meals, and there are some things that can be really helpful. So again, we want to move away from kind of bribery or anything that feels like it's putting the child in an uncomfortable position. Eat this for me, or I'll be angry, right? So we don't want to kind of leverage that sort of a consequence. But instead, helping them kind of connect the dots in the way that we just discussed around, oh, this is similar to this in this way. Kiwis are sweet, like your favorite fruit, strawberries. That can be really helpful. Instead of, after they eat something and you realize, oh, okay, they did it. They actually swallowed it. Wow. What you might be thinking in your head is, oh, that wasn't actually so bad, was it? But you want to kind of try not to say that out loud. See, that wasn't so terrible. It's kind of diminishing the fact that this actually is pretty distressing or stressful for your child in certain ways. And so it's not necessarily a productive comment to make at meal times. How did you like that? Isn't it neat how everyone likes different foods? So just asking, exploring, those are helpful types of remarks. Focusing on the fact that people have different preferences and that's okay. No dessert until you finish dinner. So kind of using the consequences in that way. Stop crying and you can have dessert. Again, there's a place for rewards, but we want to use them kind of intentionally. Instead, you can say, I'm sorry that you're sad, or I'm sorry this is so hard. Would you like a big hug? Just giving comfort. And when we start to get to the point where you're really trying to help motivate kids to try something new, say, it's okay. It's okay that we didn't try it this time. Next time we have another opportunity to try eating that blueberry. So we'll work on it next time. And again, next time it's a mealtime, you present it in front of them and you provide an opportunity to earn a sticker or something that they're working for. So it's always an option. The reward is something that they're optionally working for. It's not something we want to kind of leverage. So when you have a kiddo who's really needing to take baby steps and warm up to the idea of eating a new food very slowly and steadily, I like these food detective games. This is great for kids with autism in particular because kids with autism have such kind of active sensory processing. So really making a game of it. Ooh, maybe you present two different foods on a plate. And the goal is not even to eat them for the food detective game. The goal is just to explore them. So maybe we have a strawberry and we have a pretzel. So you just kind of go through these questions together. Oh, what does it look like? Yeah, it is. It's red. What does it feel like? Oh, it's kind of bumpy. It's kind of bumpy. Do you feel all those little bumps on the strawberry? What does the top of the strawberry feel like? Oh, that's funny. So just making a game of it. What does it smell like? What does it taste like? And so on and so forth. And of course, you can utilize things like communication devices for all of these activities. You can kind of use other visual supports where you provide kids with different options. So based on what your child's kind of overall communication profile is, you can kind of modify these strategies. And then when you get to the phase of at meal times, introducing this new food. So we're not just doing the kind of exploring the food game. It's actually mealtime. There's a plate put in front of the child. There's an expectation of eating. I recommend the rule of three. So you want to put three things on that plate, one to two of them, one to two kind of preferred foods, things that are in the green category, things that you're pretty sure that they're going to eat so that they're getting some kind of caloric intake during the meal, and then one non-preferred food. So maybe it's 1 and 1, or maybe it's 2 and 1. But that's sort of the ratio that you want to aim for. So that non-preferred food is going to be, again, something in that yellow category that we're aiming for, we're working towards. And you can apply the food detective game in the mealtime situation. If you've already kind of done that with your kiddo before and have set that foundation. You can use visual supports like you can see on the right side of the page here that are kind of modeling for kids in an illustration format what we're hoping that they'll try. And you can model this yourself with your own behavior, holding something up, smelling it, and then you try it, you smell it, tasting it, licking it, whatever you want your child to do, you can model that yourself. You can make it a whole family game as part of mealtime. We're all going to do this with this new food, this new piece of broccoli. and everybody at the table can kind of do this together. You're going to celebrate progress with rewards, avoid punishment. So we're not taking things away. We're not taking away access to, a preferred show or preferred song or something if the kiddo isn't interacting with the new food. And we're going to try to ignore any disruptive behavior. So we're focusing on forward progress here and kind of ignoring some things that might be tricky. And you want to move through this kind of hierarchy from tolerate all the way up to chew and swallow. These are the baby steps that all together kind of are the foundation of progress around meal times. Okay. So we've shared a lot of different tips and suggestions. I hope some of these were new or helpful. I see that we have a lot of comments in the chat. So I'm going to stop sharing the PowerPoint here, actually. And we can transition to taking some questions. I don't know if Sarah or Anne, have you been monitoring the chat a little bit more throughout, or have an idea of, Sarah, maybe where to start with any questions that have come through?
Yeah, I'm trying to think. I was monitoring them, but now that we're, but I didn't want to interrupt the talking part. I think there was something about juice, and I agree with the comment just to sort of mention that we had it on there as an example of like the, green, red, yellow. I agree that juice doesn't really have nutritional value. It's high in sugar, and it's not going to give you the fiber and stuff that you would get from eating the whole fruit. But and it's gonna, because it's got sugar and calories, it will fill your child up and counts as sort of anything they consume in the grazing category. So if they're drinking juice, they're not hungry. It sort of turns off their hunger mechanism. However, if you already have someone who drinks juice, you can still use that as a vehicle, right? Like you can transition maybe from juice eventually to smoothies, and then you can get more things in there. There were some comments about smoothing and smoothies and hiding things in there. Juice is also helpful as a vehicle to mix in vitamins. So the liquid vitamins or the powdered vitamins sometimes go better in juice. Or other medicines too. We didn't talk about that, but right, if your child has an ear infection and getting them to take the medicine is really, really hard. If you have juice as something that they take on a regular basis, sometimes it gives you a little bit more options. But I agree, I wouldn't purposely add juice as as like a nutritional step.
I'm going to do a rapid fire few questions because we only have 5 minutes left.
Sure.
One question was, a lot of this felt geared towards children. How do these guidelines help my 20-year-old expand? And then related to that, definitely focus on increasing the eating of vegetables and any tips. And let's say we're applying them more towards an older, a teen or young adult.
Yeah, I think a lot of that is going to be really dependent on the individual, unfortunately, and I know that's a frustrating answer to hear. But some resources that you might think about for an adolescent or adult, that really would be a good time to maybe try to connect with a psychologist. So look for maybe a referral for a psychologist, particularly somebody who has experience with the autism spectrum. And where was I going with the other piece? But when it comes to the strategies that we talked about today, a lot of these can be modified for use with adults. So it may not be in the form of play necessarily, but still the idea of keeping things kind of low consequence, low stress at meal times. It's, again, not a battle. You're introducing kind of opportunities. With adults, it's going to be more about finding buy-in or finding motivation, not so much through a reward system necessarily, but through really aligning with some way in which expanding their repertoire of foods is an important value to that individual. So really thinking more about the psychosocial pieces. Would you like to be able to go to parties and eat the same things that other people are eating? Would you like to be able to go travel or go to a coffee shop, or kind of tapping into the things that you think are important to that person and really linking the eating behavior to that piece?
then just jumping, what are some suggestions for approaching a child or a young person who has like the aversion to foods touching each other or a texture aversion?
Yeah, some of that does tend to kind of naturally decrease a little bit developmentally over time, some of those rigidities. Also, you're going to notice an overlap here where, you know, being particular about things or being rigid about certain things is characteristic of autism, and some of that is just going to spill into mealtime behaviors. So not wanting things to touch or wanting to only eat off of a particular plate or only drink out of a particular cup or only eat from one seat at the table. These things are not necessarily about the food or the consumption of the food itself, but are more a general pattern of kind of rigid or oriented around sameness kind of behaviors that you're seeing at mealtime. So kind of, but the same idea of playfully, supportively challenging individuals to become more flexible in those ways is helpful. So it might not be introducing a new food, but it might be introducing sitting at a new seat, playing musical chairs at dinner, or, you know, trying to, again, based on kind of the individual and their profile, challenge some of where that behavior is motivated from. Do they think something bad is going to happen if the foods touch? Or, you know, just explore that with them a little bit around what's maintaining that particular behavior.
So I guess one more question I'm trying to call here. Someone says, you know, it is hard to get connected to a specialist or, you know, some of the suggestions. I know certainly you mentioned or showed the Autism Speaks website, but the person is asking about just organizations or other ways to help with a child or adult who has severe eating organizations. Would you recommend the Autism Speaks above all that website or any other suggestions?
I'm not thinking of other suggestions that are coming to mind. Sarah, are you thinking of any other specific?
No, not specifically. And I guess, I mean, in terms of like where to find a feeding therapy program, I think there are some based, you know, hospital based, or out, but a lot of like the outpatient, not a lot, but some outpatient therapy centers that have speech therapy or occupational therapy. Some of them also have feeding therapy as well. So that might be if a place to look if there's somewhere you can sort of ask around, but I don't have a great resource. I agree. I live in Boston and I work in Boston and I have access to several different feeding teams and it's still hard to get people in. So if you don't live in this area, I can recognize that it might be way harder.
Alas, we're out of time. It's clear that this topic is really important and we'll certainly be hosting a coffee convo in the future on the same area. So thank you both. And thanks everyone for joining.
Good night.
Thank you.